So we're going to talk a little bit about the history and some of the conceptual basis for doing telepsychiatry today. If I can get these things to move forward. There we go. So who are the patients? What we know is that comorbid medical conditions account for up to half of all healthcare spending. Think about it. It's a lot of stuff, right? And when patients have co-occurring medical and psychiatric disorders, they're far less likely than others to adhere to prescribed medications and health advice. That may be part of the reason why there's a lot of health care resources and expenditures on this group of people. Now, as Dr. Parsi said, one of the problems and one of the things that really promotes this idea of being able to do psychiatry at a distance is that currently there's a national shortage of psychiatrists, about 6,000. What's predicted by 2025 is there's going to be 15,000 psychiatrist shortage. And part of the problem is that people are aging out. We're not producing as many as that is needed every year. And so average age of a psychiatrist is 56 years old. About 2/3 are male. 55% of the new trainees, however, are women who work on average about 1/5 of the time less over their careers than males do. And so if you think about that, that adds then a further reduction in terms of the demographics, in terms of the availability of psychiatric care. So total available psychiatric hours may be reduced about 20%, and that's in the context of the already predicted numbers that aren't going to be available. So let's do some brief history. University of Nebraska in 1959 sort of kick-started this, and remember, this is going back to black and white televisions with basically closed circuits. They used two-way interactive television to transmit neuro exams across campus to teach the medical students sort of live action evaluation. And because that was so successful, the psychiatrist said, well, this is a really good way. We might be able to do therapeutics this way. And so they used it for group therapy, long-term therapy, and consultation. Via again, these closed-circuit televisions. Then further, because it was so successful, the University of Nebraska established a link with Nebraska State, which was over 100 miles away, to provide consultation liaison, consultation essentially, to the psychiatric hospital for complex cases, for difficult cases, since that was a tertiary care medical center. Similarly, several years later in 1968, two domains, one at Mass General, the other one at Dartmouth-Hitchcock Medical Center in New Hampshire, did, again, consultation liaison type of pilot projects. The Boston MGH one was actually to Logan Airport. And they were able to do, again, this sort of closed-circuit evaluation. And the added opportunity there was that they had video. The cameras were actually would be able to be switched off so that they could actually locate the person in space and then go back and forth. And if there was another person, they could focus the camera on them. And that was kind of nifty technology at the time. And this continued to evolve over the next 10, 15 years, so that Health and Human Services Secretary directed HRSA, the Health Resources and Services Administration, and CMS to fund MedNet at Texas Tech to create a whole domain of telehealth applications. And that hummed along for a while until the next really major revolution in technology, which was the digital revolution and the harnessing of the internet via the World Wide Web, so that information started becoming digitized and video information was becoming available to be able to be sent over the internet, and there was no longer a need for closed circuit for television. So let's think about now the models of telepsychiatric care. The first two are really more within the traditional domain. One was traditional referral, and you'd be able to video conference or what have you. And the second one was to be able to do a direct psychiatric consultation, and then the consultant could actually provide psychotherapeutic or other services. The latter two are more novel in the sense of being able to do collaborative care, and you've seen enough today around hub and spoke and some of the other models that video conferencing actually allows one to participate in even though you're not there. right? And that's, the whole idea about being able to do hub and spoke is that when you're at the hub, you don't need to be at the point of care where the patient is. And the second one is this other distinction that was made today. There's been a lot of nice sort of setups through the day for some of the stuff I'm presenting, is the distinguishing between synchronous and asynchronous information. And so telepsychiatry, especially on the consult side, and for hub and spoke in general, can be useful to be able to store and forward the information to be acted upon at a later date. So it does not have to be done in real time with the patient sitting there. So let's look at a case. Here's an inpatient one, 2005. Rural hospital in Oklahoma opened up a geropsych unit with 14 beds. Couldn't staff it with a psychiatrist, and they were at risk of having it closed down. Couldn't fill the beds, couldn't get the patients seen, et cetera. So they decided to try a telemedicine intervention and see how it worked. And what they did is a pre-post evaluation. And sure enough, when they looked at patient satisfaction in all of these different areas, how helpful was the information given by staff regarding your questions about treatment? How is staff's understanding of your needs and problems? How would you rate doc's availability and attentiveness to you? How would you rate your benefit from treatment? How do you feel compared to when you came in? And how well did you achieve your treatment goals by the time you discharged? And pretty much across the board had statistically significant findings. And you're going to find this pretty much throughout telehealth, that these interventions work, that they typically don't do any harm. In other words, when you have competent professionals at the other end of the video, people use good clinical judgment, and it works out pretty well. Another case is to use it in emergency departments. Why would we think about telepsychiatry in a medical ED, a med-surg ED? Well, it turns out between 1992 and 2001, there's been a 29% increase in mental health-related emergency department visits, and most, as then and now, most ED providers don't really feel comfortable to care directly for psychiatric patients. And complicating it is that about half of ED physicians have experienced at least one daily and often more psych patients being boarded in the EDs awaiting a psych admission bed, right? So they back up, and then people complain, and it screws up the workflow. So here's a case in a large not-for-profit hospital system in South Carolina with 20 acute care hospitals, the standalone EDs, and they experienced the same rise in psychiatric visits to the EDs. And their problem in this system was that the psych visits did not generate enough revenue to support a full-time psychiatrist, and they couldn't find enough psychiatrists to populate the system anyway with all of those locations. So the result of that is patients would sit essentially boarded in the ED for days sometimes without any psychiatric care, awaiting transfer to a psych hospital. So they did a pre-post survey of the data. They had gotten 7,261 patients that had indexed telepsychiatry visits that they could match to controls. And this is from 2009 to 2013. And what they found was significant results, right? And these are important. They have the psychiatric admissions from 22% to 11%. When they were admitted, the length of stay was decreased. They had improved 30 and 90-day follow-ups. And then when they were admitted, the 30-day overall health cost for the inpatient stay was significantly lower. So a significant set of advantages. So I talked about asynchronous flow. This is kind of how it works. Primary care provider is supported in doing a patient-clinician virtual visit. It's stored and archived in the video file, which is then forwarded to the psychiatrist. Again, asynchronously at some other point in time. Psychiatrist spends time with it, goes through it, writes a consult note and recommendation, and sent back to the primary care provider. And then you can look at all the different outcomes that come with that in terms of patient satisfaction, treat to target, all that good stuff. So it turns out that one of the major benefits is that you don't get the no-shows. And in psychiatry, there's a significant no-show rate, especially at a clinic level. When you have a private practice, you usually have a bit better number, but when you're in a clinic situation, there's a significant no-show rate. And so we know that 10 to 20% of patients just don't show up, and about half of the people who don't show up just drop out of treatment. And of course, that's associated with increased morbidity and mortality. The other part that's positive here is that it's efficient to do these consultations. You can do an asynchronous telepsychiatry consultation in about 30 minutes. So it's pretty good. It's a pretty good model. I'm going to jump over that. So when we think about collaborative care, which we've heard about today in terms of the ideas, there are about 5 different domains that sort of are associated with that. The first one is patient-centered team care. And you've got basically something that is aimed at supporting patient autonomy in his or her engagement with the healthcare delivery system, and a team of providers, not just a solo practitioner, but a group of healthcare professionals with different disciplines and different skill sets that are aligned around the patient, so that the patient is the central focus. The second one is the opposite. It's looking at the large mass of people, called population-based care. And that's where you use registries to track how are lots of patients with this particular problem doing over time, right? And what it does is that kind of follow-up allows you to track and not allow patients to fall through the cracks. Patients, for example, with co-occurring psychiatric and substance use disorders typically fall through the cracks because there's a lack of an already generated, integrated system of care for them. Then you use treatment to target, and that works in psychiatry as well as it does in diabetes care, right? So you use screening tools, for example, to track patients' progress and then look at severity measures over time. The next one is evidence-based care. Both psychosocial and pharmacologic interventions have an evidence base, and you use the ones that have the evidence base for the disease or the disorder that you're treating, and that's self-evident. And then the last one's accountable care, where telehealth and telemedicine and now telepsychiatry have been problematic, but accountable care organizations are focused around care integration, reliable performance measurements, but the next-gen ACOs are now allowing telehealth in their models. And it's good that CMS apparently has taken up the baton, because that's obviously going to help that succeed. What are some of the modalities we use in telepsychiatry? The same modalities we use in face-to-face psychiatry: individual, family therapy, group therapy, and there's a new modality which is self-administered, which means you can have reliable and valid interventions where there is no therapist. There's a set of modules where patients or people can go on the internet, or they can have it prescribed by their clinician to work through these, for example, cognitive behavioral therapy models around a particular, phobia, a particular disorder, and there's a reasonably good evidence base for some of those. The problem is there's a lot of stuff out there, and a lot of it's junk. That's part of the problem. Okay, let's look at the telegroup case. Veterans suffer from insomnia disproportionately to the rest of the population. Psychologists at the VA created a cognitive behavioral insomnia program for them, but a lot of the patients live too far away from the VA medical centers to really make use of those therapies, so they looked at a telegroup therapy. So it was veterans at a community-based outpatient clinic. They used software called Jabber, and with this they were able to use to go between the different patients at their own locations. Most of them are home, and you can actually then have all of the people represented and move from one to the other using the software. And it's a modularized intervention. It's 6 sessions. They go from 60 to 90 minutes, and it's modularized, so it has a start, beginning, middle, and end. And here's just the clinical impact. Basically all kinds of scores having to do with quality and latency of onset of sleep were, clearly statistically significantly improved from the beginning to the end of the therapy, in case. For the group therapy intervention. So it works, and there's no reason to suspect why it wouldn't if the therapy works and the mode of translation of the information back and forth between therapist and patient is not obscuring that level of communication, then one would suspect that it should work, because it's really then it's just the delivery vehicle, and in this case it's audiovisual, and it supports it. So here are some of the self-administered e-therapies. Again, you have to do your homework, find out what is approved or supported by professional organizations and has some kind of merit. Right now they're sort of working on these standards. There was some talk earlier in terms of FDA approving devices. Well, there is movement afoot now to kind of certify psychosocial interventions or digital or smartphone-based applications that do e-therapies, and that's a good thing.